Welcome to Week 4. We've covered measures of disease frequency and association. Now we turn to study designs, starting with descriptive epidemiology. Descriptive epidemiology answers the basic questions: who is getting sick? Where is disease occurring? When does it happen? These seem like simple questions, but the answers often reveal patterns that lead to major discoveries. For healthcare managers, descriptive epidemiology is your starting point for needs assessment, resource allocation, and identifying problems that need investigation. Before you can solve a problem, you have to describe it. Descriptive epidemiology organizes around three dimensions: person, place, and time. Person characteristics include demographic factors like age, sex, race/ethnicity, and socioeconomic status. They also include behavioral factors like smoking, diet, and physical activity. Occupation matters: certain diseases cluster in certain jobs. Personal medical history, genetics, prior conditions, shapes risk. Place can be analyzed at multiple scales. Global patterns: why is stomach cancer common in Japan but rare in North America? National patterns: why do maritime provinces have higher heart disease rates? Local patterns: why does this neighborhood have elevated lead levels? Time patterns include secular trends over years or decades: how has lung cancer mortality changed since 1950? Seasonal patterns: influenza peaks in winter. Epidemic curves: how does an outbreak unfold over days or weeks? These dimensions interact. Disease patterns by age might differ between places. Time trends might differ between demographic groups. Descriptive epidemiology maps these patterns, generating hypotheses for analytical studies to test. The simplest form of descriptive epidemiology is the case report, a detailed description of a single patient's presentation. Case reports might seem primitive, but they've been crucial for identifying new diseases. The first description of AIDS came from a case report in 1981 describing pneumocystis pneumonia in a previously healthy gay man, a disease that simply didn't occur in immunocompetent people. A case series collects multiple similar cases and describes their common features. After those initial AIDS case reports, investigators compiled case series showing clusters of opportunistic infections and Kaposi's sarcoma in young gay men in Los Angeles and New York. Case reports and series are hypothesis generating, not hypothesis testing. They can't prove causation or even association. They can't calculate incidence or relative risk because there's no comparison group. But they're often the first signal. New drug adverse effects frequently surface through case reports. Novel infectious diseases are first recognized through unusual case presentations. Healthcare managers should pay attention when clinicians report seeing something strange. For quality improvement, case reports of adverse events are your starting point for investigation. The medication error that harmed one patient might indicate a systems problem affecting many. Cross-sectional studies measure exposure and disease status at the same point in time, a snapshot of the population. The Canadian Community Health Survey is a classic cross-sectional study. Respondents are asked about their current health status, current behaviors, and demographics. From this, we can calculate prevalence of diabetes, proportion who smoke, and associations between factors. Cross-sectional studies give us prevalence, not incidence. We know who has disease now, not who developed it recently. For chronic conditions, most existing cases are long-standing. The major limitation is temporal ambiguity. If we find an association between physical inactivity and obesity, which came first? Did inactivity cause obesity, or did obesity lead to inactivity? Cross-sectional data can't answer this. For healthcare managers, cross-sectional studies are invaluable for needs assessment. What is the burden of disease in your catchment area? What health behaviors need attention? What services are being utilized? This information drives planning. But don't overinterpret cross-sectional associations as causal. An association between income and health status doesn't tell us that poverty causes poor health, though it might. Other designs are needed for causal inference. Ecological studies analyze data at the population level rather than the individual level. Instead of asking whether individuals who smoke get lung cancer, we ask whether populations with higher smoking rates have higher lung cancer rates. These studies are efficient. You can use existing aggregate data without individual level measurement. They're useful for generating hypotheses and examining population-level exposures like air pollution or water fluoridation. The classic example is the relationship between national dietary fat consumption and breast cancer rates. Countries with higher fat intake have higher breast cancer rates. This generated hypotheses about dietary fat and breast cancer. But ecological studies are subject to the ecological fallacy, the error of assuming that associations observed at the population level apply to individuals. Maybe countries with high fat intake also have other characteristics that cause breast cancer. And within those countries, it might not be the high-fat consumers who get breast cancer. As it turned out, individual-level studies found weaker associations between dietary fat and breast cancer than ecological studies suggested. The ecological correlation reflected confounding at the population level. For healthcare managers, ecological analysis across units, hospitals, regions, time periods, can identify patterns worth investigating. But be cautious about inferring individual-level relationships from aggregate data. Let me illustrate descriptive epidemiology with the Canadian opioid crisis, tragically relevant to healthcare management. Mapping opioid overdose deaths reveals stark geographic patterns. British Columbia has been the epicenter, with overdose rates 2 to 3 times the national average. Alberta and Ontario follow. Within provinces, urban areas like Vancouver, Edmonton, and Toronto have highest rates, but rural areas are increasingly affected. Time patterns show dramatic trends. Overdose deaths roughly quadrupled between 2016 and 2021. The COVID-19 pandemic accelerated deaths as the toxic drug supply worsened and services were disrupted. Person characteristics reveal high-risk groups. Young and middle-aged adults, predominantly male. Those with mental health conditions and histories of substance use. Indigenous peoples are disproportionately affected. People experiencing homelessness or housing instability. This descriptive epidemiology guides response. Where should supervised consumption sites be located? Which populations need targeted outreach? How should naloxone distribution be prioritized? For healthcare managers, this is applied epidemiology. The ER manager seeing the daily reality of overdose presentations benefits from understanding the broader patterns. The patterns inform staffing, training, and advocacy for system changes. When investigating outbreaks, the epidemic curve is your most important descriptive tool. An epidemic curve, or AP curve, plots the number of cases on the y-axis against time on the x-axis. The shape reveals critical information about how the outbreak is spreading. A point source outbreak, everyone exposed to a single source at one time, produces a characteristic sharp peak. Cases rise rapidly after the incubation period, then fall. Food poisoning outbreaks often look like this: everyone ate the contaminated potato salad at the church picnic. A propagated outbreak, person-to-person transmission, produces multiple waves. Each generation of cases infects the next, creating a series of peaks roughly one incubation period apart. Respiratory virus outbreaks often show this pattern. A continuous common source outbreak, ongoing exposure to a contaminated source, produces a plateau pattern. Cases continue as long as exposure continues. The AP curve also helps identify the likely exposure time. Work backward from the peak by one incubation period and you're in the window when exposure occurred. For healthcare managers, AP curves help you understand and communicate about outbreaks in your facilities. Is this a single exposure event or ongoing transmission? Are control measures working? The visual tells the story. Surveillance systems provide ongoing descriptive epidemiology, continuous monitoring for patterns that need attention. Canada's National Notifiable Disease Surveillance System compiles provincial reports of designated diseases, tuberculosis, measles, invasive meningococcal disease, and many others. Each province has a list of reportable conditions that healthcare providers must notify to public health. Syndromic surveillance monitors symptom patterns before specific diagnoses are made. Emergency department chief complaints are monitored for unusual clusters, respiratory illness, gastrointestinal illness, rash. This can detect outbreaks faster than waiting for laboratory confirmation. Laboratory-based surveillance tracks pathogen identification. When labs identify Salmonella, they report serotypes to PulseNet Canada, enabling detection of multi-jurisdictional outbreaks. Vital statistics systems track births and deaths, providing mortality surveillance. Cancer registries systematically collect all cancer diagnoses. For healthcare managers, understanding surveillance helps you contribute to it. Your facility's data feeds into these systems. And surveillance alerts, like notifications of increased influenza activity, inform your operational planning. During COVID-19, surveillance systems were stressed to their limits. The pandemic revealed gaps that Canada is now addressing. Let's summarize descriptive epidemiology. Person, place, and time are the organizing dimensions. Who gets sick? Where does disease occur? When does it happen? These questions reveal patterns and generate hypotheses. Case reports and case series are hypothesis generating. They can't prove causation, but they're often the first signal of new diseases or adverse effects. Pay attention to unusual cases. Cross-sectional studies provide snapshots, prevalence at a point in time. They're excellent for needs assessment but can't establish temporal sequence or causation. Ecological studies analyze population-level data. They're efficient but subject to the ecological fallacy. Associations at the population level may not reflect individual-level relationships. Surveillance systems provide ongoing monitoring for disease patterns. Understanding these systems helps you contribute to them and use their outputs for planning. For healthcare managers, descriptive epidemiology is foundational. Before implementing interventions, you need to understand the current situation. Who is affected? Where? When? This drives rational resource allocation. Next week, we move to analytical epidemiology, cohort studies and case control studies that can establish associations more rigorously. For your assignment, obtain descriptive data about a health issue in your region, from your organization, public health, or CHE. Describe patterns by person, place, and time. What questions does this raise? See you next week.